So as we get ready, I want to thank the webinar series team who puts these events together. It takes several of us to make this happen for you, and I just want to say thank you to the whole team, and that's who you see on your screen. We also have a live Spanish interpreter today. We have a live person. This is not AI interpretation. If you would like to hear the webinar in Spanish, you can go down to the bottom of your screen and you will either see a little globe or a circle with 3 dots that says more. And you can click there and select the interpretation channel, and you can hear that live translation of the audio today, if that's something that you'd like to do. So thank you to Zita Thompson, who is our translator today. We appreciate that. I also wanted to let you know this webinar, as I'm sure you know, is hosted by Lecturio. So if you're interested in learning more about our platform, you can book a meeting with someone on our team. So you can use the link that you'll see appearing in the chat right now, or there's a QR code on your screen that should allow you to scan it with your phone and take you to a place to book a calendar appointment to do that. My name is Sarah Keith. I'm the Director of Learning and Institutional Success here at Lecturio, and I'll be your host today. But our guest speaker today will be the one bringing you all of the good information, and that's Dr. Nathan Stehouwer from University Hospitals Cleveland Medical Center, where he is an associate professor. And he's also a member of the NEJM Healer Advisory Board. So I am going to hand it over. Thank you so much.
Yeah, thank you so much, Sarah, and to the Lecturio team. I'm going to pull up my slides here. Great. Well, thank you everyone for joining. It's really exciting to see the range of places everyone is calling in from and range of positions and professional interests represented. As Sarah mentioned, I am an associate professor here at Case Western and University Hospitals in Cleveland, Ohio. I teach both internal medicine and pediatrics, and so I'll be making reference to both some adult and pediatric cases as we go through here. My goal in talking to you all today is really to first provide an overview of how I see the evidence around practices that can best support the learning and ongoing improvement of our trainees as they learn clinical reasoning. And then to shift into talking about how explicitly probabilistic reasoning can be a seamless part of those practices and, in fact, effectively support those practices to maximize the learning of our trainees. And I'll talk about some specific practices and strategies and tools that I have found helpful in teaching clinical reasoning using explicit probability. In terms of disclosures, I am on the editorial board for the NEJM Healer product, which is a Lecturio product. I have no other financial disclosures. This talk really begins with this question of how we can teach our learners to reason better. I'm going to be largely talking about diagnostic reasoning, a process of categorization. We'll talk a little bit about how the use of probability does effectively link to management reasoning, however. What do we mean by reasoning better? Are we talking just about the process of reasoning, or are we judging based on the quality of output, their diagnostic accuracy? Obviously, diagnostic accuracy is the ultimate goal, but we'll talk about how looking under the hood and examining specific reasoning practices offers lots of opportunity for giving constructive feedback and providing effective coaching to our learners. And what are we teaching? Are we providing tools that will help our learners to immediately reason better? Or are we providing strategies that will help them to enhance their learning and their ongoing improvement? And I think it's this last question that's the jumping off point for a really interesting literature looking at what it means to reason more effectively. Going back a long time in medicine, there's been an interest in the idea that if we can find out how expert clinicians are reasoning, we can then work backward to the strategies that we need to teach our learners, and then they too will be more effective clinical reasoners. I'm not going to bury the lead on this. Those sorts of approaches have largely been ineffective at improving clinical reasoning, either in trainees or in practicing clinicians. Studies going back to the 1970s demonstrate that novices and experts are using more or less the same cognitive structures as they engage with clinical cases. They're generating hypotheses, testing out those hypotheses against the available clinical data. It's just that experts are doing it much better and generating accurate hypotheses early in clinical cases. We'll talk about some important caveats and ways in which we can teach effective strategies, but it's more than just teaching the process extracted from specific case content. More recently, there's been a lot of interest in utilizing the dual process model of reasoning, where System 1, automatic intuitive processing, generates hypotheses automatically based on pattern recognition. And then System 2, which is conscious, effortful, analytical reasoning, monitors System 1 and has opportunities to intervene and correct the errors, which are, in this view, often generated by System 1. Again, strategies focused on either pushing clinicians into using analytical reasoning, System 2 processing, or strategies focused on teaching our learners about cognitive biases to de-bias System 1, have largely been ineffective in improving clinical reasoning. What does seem to relate to successful diagnostic accuracy is case-specific content. And to put this in some context, I practice internal medicine and pediatrics. I like to think that I can pretty effectively evaluate a patient with acute onset of shortness of breath or prolonged fevers. If you put me in labor and delivery triage, I'm going to look like much more of a novice. The same cognitive strategies don't necessarily carry over, but case-specific content and experience with specific cases does seem to predict diagnostic accuracy to a greater degree. And that's led to interest in the performance improvement literature more broadly, and particularly the work of Anders Ericsson, who described what it took to achieve mastery performance in a variety of domains, famously studying professional violinists and looking at the practices that led to expertise. And this was the origin for the often somewhat oversimplified 10,000 hours rule, the idea that 10,000 hours of repeated practice in a given domain will result in expert performance. This is certainly a piece of the puzzle in medicine, but it's not just experience. For one thing, the literature on the relationship of time practicing, of experience or age with diagnostic performance is a very mixed bag. Certainly there's improvement over the course of training and in the first year of practice, but after that time, both in studies using standardized diagnostic cases and in real clinical practice, the evidence would suggest that if anything, there might be a decline in diagnostic accuracy over the course of our careers. And in any domain, there is a tendency to hit natural plateaus with ongoing time and ongoing experience, that performance may not continue to improve at the same rate or may stop improving entirely. And again, I think we can lean hopefully on the work of Anders Ericsson in thinking about what are the practices that help us to move past those plateaus in performance. What are the practices that can help our learners to achieve ongoing expertise over the course of their careers, as opposed to becoming what Gurpreet Dhaliwal calls experienced non-experts. And what Ericsson found is that a set of practices, which he refers to as deliberate practice, helps to lead to improvement that breaks through these plateaus and leads to expertise. Deliberate practice requires a motivated learner, and yes, extensive time and repetition. But critically, deliberate practice requires the availability of high-quality, immediate feedback, coaching, and the ability to try out new methods to experiment with one's own performance. So feedback is one of the key ingredients that helps to predict the development of expertise with ongoing experience. But feedback is a huge challenge in medicine. Feedback in medicine, especially after we complete formal training, is, if it's received at all, often delayed, limited, ambiguous, sometimes even directly misleading. Imagine a scenario where I'm taking care of a patient with a cough that's due to a viral syndrome. I decide that just to be safe, I'm going to order a chest x-ray that the patient probably never needed. The chest x-ray shows a possible developing infiltrate, and so I decide that I better order antibiotics just to be safe. The patient improves, as they were going to anyway, from their viral syndrome, and they're very grateful for my attentive care. What lesson have I learned from that case? And it's not hard to think of many, many examples like that in medicine. And these sorts of scenarios are part of why ongoing experience without high-quality feedback can lead to increased confidence, but not necessarily increased performance. There's another piece we should consider as we consider what it takes to achieve ongoing improvement. I told you that generalized cognitive strategies, or nudges to utilize System 2 processing, have largely been ineffective as strategies for diagnostic improvement. The results are different for strategies that directly activate learners' knowledge in the context of specific cases. And one strategy that I find very interesting is deliberate reflection. Deliberate reflection involves, after a learner has engaged with a clinical case and generated a diagnostic hypothesis, challenging that learner with the following set of questions. Which clinical findings support your hypothesis? Which clinical findings argue against your hypothesis? Which findings should have been there had your hypothesis been correct? And then, having considered those, what alternative hypothesis would you consider if your initial hypothesis were incorrect? After repeating steps 1 through 4 and generating sufficient hypotheses, then rate the alternative hypotheses in terms of likelihood. Notice how these questions make reference to learners' content-specific knowledge about the case. And what I find really exciting about this is that deliberate reflection not only improves diagnostic accuracy when used for challenging cases, which is to say more simple cases for junior learners and more complex cases for more experienced practitioners, but of great interest as an educator, deliberate reflection improves learning. Learners who engage with clinical cases using strategies of deliberate reflection subsequently perform better in terms of diagnostic accuracy on similar and related cases in the future. So to sum up where we are thus far, diagnostic reasoning is dependent on structured knowledge gained through experience with feedback and enhanced by deliberate reflection. So far, so good. I'd like to talk now a little bit about how we can specifically use tools of probabilistic reasoning to enhance learning through each of these three components. Just a little bit about terminology. I'm going to be referring a lot to probabilistic reasoning. And very simply, by probabilistic reasoning, I mean clinical reasoning that uses explicitly probabilistic language. And to be clear, while I favor using numerical probability, I think you can achieve the same goals using plain non-numerical probabilistic language. As you see here for reference, there's a fair amount of literature linking the terminology we use to probability. And while I think there are some advantages in precision to using numerical probability, I also realize that this is a major stumbling block for many of us and for many of our learners. But this is in contrast to mere logical reasoning or pattern recognition. I'm also going to be referring to Bayesian reasoning, a specific form of probabilistic reasoning utilizing Bayes' theorem. Bayes' theorem rests on the recognition that the impact of a new piece of data on probability is a function of the pre-existing probability and then the diagnostic weight of that new piece of data. And mathematically, this can be expressed as the odds of a disease are equal to the pretest odds times the likelihood ratio. Whether or not we want to use numerical probability in describing these, I think we can do our learners a great service by emphasizing the degree to which different data move the needle in terms of diagnostic probability. We can help our learners to differentiate data with, for instance, a likelihood ratio of 1.5 to 2 that provide moderate support for a hypothesis, and data with a likelihood ratio of 5, 10, or even greater that provide strong support. And here you see a graphical illustration of the impact of different pieces of information on the probability of a patient having acute coronary syndrome, patient presenting with chest pain. And these sorts of graphical illustrations, as well as going through the numerical process, can be helpful with our learners. One more piece of terminology that I want to mention that I'll be referring to are Breyer scores. Breyer scores are a tool I've found particularly helpful in evaluating and giving feedback on probabilistic diagnosis. Breyer scores are used extensively in fields that rely on probability, like weather forecasting. And the important thing for you all to know about Breyer scores are that a user maximizes or optimizes their Breyer score by accurately appraising their own level of certainty. The best predictions that are rewarded by Breyer scores are useful and trustworthy. They're useful in the sense that it's much more useful to be told that there is either a 10 or a 90% chance of rain than that there's a 50% chance of rain. But that's only helpful if those numbers are trustworthy, that in cases where you're told there's a 90% chance of rain, it rains 90% of the time, and that in cases where you're told there's a 10% chance of rain, it rains 10% of the time. The same principles work for diagnostic probability, and Breyer scores reward learners who can, yes, recognize high probability instances, like the fact that a patient with cardiac risk factors who is coming in with exertional substernal chest pressure has a much higher likelihood of coronary artery disease than the healthy 25-year-old with pleuritic chest pain, but also encourages learners to appropriately calibrate their own level of certainty. So let's return to these three domains we talked about. How can we use principles of probabilistic reasoning to enhance learning through experience? Certainly, as we've seen, we need to find ways to maximize clinical experience generally. We need to find ways to expose students to a breadth of cases, including common diseases, but also rare and more critical diagnoses. This sometimes can mean necessarily overemphasizing rare diagnoses relative to their frequency. Students' intuitive sense of base rates will be informed by the rate at which they are exposed to different cases. And while we all aspire to be the clinician who can make a rare or challenging diagnosis, it may well be that the more important marker of being a master diagnostician is the ability to reliably differentiate common and overlapping diagnoses. And this gets to an important challenge, which is how to teach about common diagnoses in a way that is challenging and engaging for our students. I want you to consider this case of a 2-month-old boy who's coming in with 3 days of cough, rhinorrhea, increased work of breathing, had some emesis at home, no fevers, did have an episode of perioral cyanosis before seeing his pediatrician. The patient has a sister with similar symptoms. The family comes from the nearby Amish community. In the pediatrician's office, the patient is afebrile, tachycardic, has a respiratory rate of 65, and a pulse ox of 87% on room air, with diffuse crackles and wheezing noted, mild subcostal retractions, and a soft systolic murmur. Consider options 1 and 2. Which of these questions do you find more challenging? And what questions come to your mind when you consider this case through the lens of question 1 as opposed to question 2? I invite anyone to put responses into the chat. Yeah, I agree. And I see there's a question in here, and I just want to briefly address the reflective practice and deliberate reflection. Deliberate reflection is a bit more specific than reflective practice. Deliberate reflection is a term coined by a group of authors, Mamede and Schmidt, who described a very specific set of practices. Certainly, reflective practice more broadly, and it sounds like this is something you've thought about a lot, is a valuable piece of education. So I see a lot of option 2 answers here. Option 1, and I realize not everyone here practices pediatric medicine, but once you see that bronchiolitis is statistically certainly the most likely option, it's pretty easy to find evidence to support that. Option 2 for most people is a bit more challenging. Sure, bronchiolitis is the most likely. Is it 60%? Is it 95%? And maybe more relevantly, what's the likelihood of congenital heart disease? Is it a mere afterthought, or is it a 10% probability that requires some further evaluation? Notice the types of questions that this activates. What's the rate of congenital heart disease in this patient's community? How severe and prolonged was the patient's hypoxemia? Go back and examine that murmur with some, with a greater degree of intention. I think this sort of question can convert a case that for our learners can fairly quickly become automatic into a really rich learning opportunity. And there's an added and subtle challenge, especially as we think about constructing simulated or practice cases for our learners, which typically are, not always, but typically are oriented around a specific diagnosis and written to lead to a very specific diagnosis, and often in a somewhat unambiguous way. Uncertainty is a huge part of the practice of clinical medicine and can be very uncomfortable. And in fact, physicians who have a low tolerance for uncertainty are responsible for substantially increased resource utilization, accounting for 17% or more increased cost simply related to excess diagnostic testing. And students with a low tolerance for ambiguity, a distinct but related phenomenon, are at increased risk for burnout and tend to avoid future careers that bring them into closer contact with high-risk, high-need populations. And there's unsurprising evidence to suggest that our students and junior trainees feel the potentially detrimental impacts of uncertainty even more strongly and feel a stronger sense than more experienced practitioners of a need to demonstrate confidence or a high degree of certainty. And this is one of the things that I find really helpful about converting clinical discussions into discussions about probability. Unless you are putting forward a probability of 0 or 100%, on a specific case, there's really no such thing as being right or wrong. But there is absolutely such a thing as putting forward a better or worse prediction, and certainly a more or less well-justified prediction. I find that the use of openly probabilistic language in clinical settings, in outpatient clinic, on the wards, really opens the door for frank and productive engagement with uncertainty, rather than learners feeling they need to quickly move to that more comfortable place of complete certainty about a diagnosis. And I think that we do our learners many more favors by preparing them with productive tools with which to engage with uncertainty, rather than leaving it as this very uncomfortable phenomenon for them. Probabilistic diagnosis also really facilitates team input. This looks at probabilistic forecasts submitted in a couple different settings. Incidentally, lower Brier scores are better. And when you put together probabilities submitted by individuals, you lead to pretty substantially improved probabilistic diagnoses. And this is an exercise that I really enjoy doing with my teams when I'm rounding in clinical settings. When we're considering a particular scenario, everyone submits a diagnostic probability, we put them together, and then we utilize that diagnostic probability as a beginning point for our discussion of various testing and management options. I think this really helps to promote the engagement of learners at a range of levels. And in fact, when you have inputs from a diverse group of practitioners, the aggregated output is in fact improved. And so really enhances engagement of the entire team. And then provides a very direct link into discussion of management decision-making. Management reasoning is its own very complex topic. There's a lot to weigh in terms of risks and benefits of various treatments, risks of testing options. But for any diagnosis, when considering a particular treatment, for a particular patient context, there's going to be some threshold above which it's worth starting treatment, even without complete certainty. That threshold might be very different. An oncologist will want a very high degree of certainty before beginning chemotherapy. An emergency medicine doctor will need only a very modest probability of bacterial meningitis to begin empiric antibiotics. But that development of diagnostic probability is a beginning point and a very helpful tool for framing this conversation for our learners. I'm going to shift gears a little bit to thinking about how we can use probability to enhance feedback for our learners. Broadly speaking, feedback around diagnostic reasoning can be oriented around the process of reasoning or around the outcome. And to think about the process, I'm going to lean on this model of clinical reasoning taken from Dr. Bowen's 2006 review on strategies to promote clinical diagnostic reasoning in education. In this model, the clinician engages with the patients and acquires their history, physical, and from that data, abstracts out what's called a problem representation. A problem representation is an abstract mental model of the case. The best analogy I've heard from this comes from Dr. Bowen, who likened this to the word problems that many of us solved in elementary school math class. Johnny is biking 5 miles per hour west, and Susie is biking 10 miles per hour east. Their houses are 30 miles apart. When will they meet? A problem representation is distilling out from all that verbiage that the problem you're being asked to solve is the problem of distance over speed equals time. In a similar way, a problem representation of a patient in the emergency department might involve distilling out from the very large amount of clinical data generated that you're being asked to solve the problem of a middle-aged man with crushing substernal chest pain, for instance. That problem representation will lead to the generation of hypotheses, and for each of those hypotheses will be considered in light of the clinician's illness script. which is a mental structure in which we record our own internalized picture or story of a given disease. And I say story because we tend in these to emphasize the background in which this disease occurs, what goes wrong pathophysiologically, and what are the consequences? What happens to the patient as a result of the disease? The clinician is then going to match up that illness script with the data from the particular patient, which will lead to accepting or rejecting the diagnostic hypothesis. I'll talk a little bit about problem representations and then briefly about illness scripts in light of how we can use probability to teach our learners and coach our learners in these concepts. Problem representations can include information about who the patient is, important risk factors, geographic factors, etc., what the defining features of the symptom complex are, and the time course, the tempo, the interval over which clinical symptoms are developing. And to illustrate this, I would invite you all to take 1 or 2 minutes to consider this case and write out for yourself a problem representation. I promise I won't ask anyone to put theirs in the chat, but please just take a minute to read this case and sketch out for yourself how you would represent this case to yourself. And yes, to Brina's question, problem representation is similar to a summary. The concept is based on something that we see clinicians doing automatically, but refers a little bit more to your own internal representation of the key features of a case, slightly distinct from a summary that you might use to, for example, hand a patient off to someone else or describe them to the next clinician. And hopefully the next 2 slides will help to make that distinction clear. So consider your own problem representation for this case. And now take a look at these 4 options. And if we could please put up the survey, I appreciate everyone could vote for 1 through 4, which you think is the most useful problem representation, which best links up with the version that you put forth. All right, excellent. I'm glad to see there's some, got it. I'm glad to see there's some disagreement, and because I think there's a lot of interesting conversation to be had as we think about these different options. Certainly option number 2, and to be clear, each of these is an accurate description of the case, and each of them has their uses. Number 2, I think, would be a better example of a summary. If you had to document your findings about this patient's history, if you had to hand this patient off, a higher level of detail as seen in number 2 would certainly be useful. There's a couple ways of thinking about the sort of feedback we would give to our learners when we ask them to make their own reasoning, their own problem representation explicit. So one is based on the language that they're using as they describe the patient. One thing that we see in expert clinicians is that more and more they describe the patient using these encapsulated terms that convey a whole host of meaning for them. And so, for instance, a clinician might describe this patient as having acute diffuse abdominal pain or acute exudative pharyngitis, which conveys a lot of clinical meaning extracted out from just the raw clinical data of this patient had 3 days of sore throat, for instance. That leaves us with the challenge of how to select the data to foreground as we are representing cases to ourselves to be solved. In this case, a number of you were interested in number 1, a number were interested in number 4. And it comes down to this question of how do we select? Do we want to emphasize the patient's abdominal pain? Do we want to foreground the patient's pharyngitis? These are challenging questions. There's not always clear answers. I think that principles of probability can help students to understand why one might be selected rather than another and to give some feedback on this. For instance, why did some of you want to foreground the abdominal pain? What was more pressing about that? And what did some of you find more helpful about the pharyngitis? And how about this patient's caps? Probabilistic reasoning highlights that key clinical data for the problem representation should help to define a reference class, an anchor point for that differential diagnosis. And the anchor point should help to restrict a differential diagnosis without excluding major likely causes. From that point, additional data in the problem representation should really emphasize pieces of information with high or low likelihood ratios for key diagnostic hypotheses. So for instance, in this case, I would argue that foregrounding the exudative pharyngitis is more helpful than the diffuse abdominal pain. The diffuse abdominal pain is undoubtedly very important to the patient who's experiencing it, but is associated with a broad range of conditions and acute illnesses of childhood, whereas the exudative pharyngitis provides a narrower and more specific differential diagnosis from which to build your diagnostic approach. And from there, you can look for the pieces of information that have a particularly high or low likelihood ratio for some of the additional diagnoses for consideration. And I've listed here a few clues that I often use in talking to learners about helping to identify data that are likely to be more predictive. We can use some of these same principles as we think about emphasizing illness scripts for our learners. I've mentioned that illness scripts are an internalized story of a patient's condition. Think about these two very brief descriptions. These are not a full illness script, but these descriptions of acute interstitial nephritis. On the left is what I thought of acute interstitial nephritis when I was a second-year medical student. And on the right is how I tend to think about acute interstitial nephritis now. Both of these are certainly accurate. And of course, we would want this fleshed out with a lot of additional details about the manifestations of a given condition. But I find that the representation on the right, emphasizing who gets this and in what context we see it, ends up being much more clinically useful than the representation that highlights the physiology and the classic triad that occurs in such a small minority of patients. And this is something that we see in experts as novice learners move towards expertise. They spend their illness scripts emphasize more and more strongly the background, what's referred to as the enabling conditions, that highlight in what scenarios, in what contexts, in which patients a disease is likely to show up. Probabilistic diagnosis, I think, really shines when we think about how we can give our learners feedback on outcome, which is to say diagnostic accuracy. Here's some data from a study we did at Case with senior medical students, looking at the use of Breyer scores to evaluate students' performance in probabilistic diagnosis. And Breyer scores were predictive of final diagnostic accuracy in these low fidelity simulated cases, had a trend towards association with more efficient test utilization, and as would be expected, correlated directly with knowledge content that was specific to the cases being predicted. And there's some indication that Breyer scores may actually be a more sensitive marker for skill than simply diagnostic accuracy. I find this to be a very helpful tool for coaching in particular. And I've used this approach, and incidentally, at the end, I'll share a link, and happy to share specific resources with anyone. But I find this to be a very helpful tool in coaching learners who have been referred for remediation, learners who have been identified with having issues with overconfidence or underconfidence, because this approach helps to highlight the important role of calibration of one's own level of certainty, as well as the accuracy component of recognizing the most likely diagnoses, and provides really concrete evidence to support those sorts of assessments that otherwise can feel so subjective. Lastly, I want to come back to reflection. Let's think about deliberate reflection through the lens of probabilistic language. As we've seen with problem representation and illness scripts, we can enhance deliberate reflection by emphasizing the degree of support or refutation that's provided by clinical data. Which clinical findings moderately or strongly support your hypothesis? Which findings moderately or strongly speak against the hypothesis? And which findings should have been there some of the time or all of the time had the hypothesis been correct? And note the final question: rate the alternative hypotheses in terms of likelihood. Many of you may have seen this example of Steve drawn from Daniel Kahneman's book, Thinking Fast and Slow. Imagine being asked about the case of Steve, who lives in Chicago and is quiet, introspective, and in the evenings enjoys unwinding by himself at home with a cup of tea. And the question is, what are the odds that Steve is a librarian versus salesperson? The challenge here, and I think in the interest of time, I won't make you go through the effort of responding, though I certainly invite you to think through this, is that the automatic tendency is to ask yourself the question, how much does Steve sound like my picture of a librarian? As opposed to asking, in cases like this, how many people are librarians versus salespeople? This is used by Kahneman to describe what he calls taking the outside view before the inside view. In the United States, there's about one person working in library science for every 100 people working in sales. And so your starting point is that the odds of Steve being a librarian versus a salesperson are about 1 to 100. Now, you could look for data on how likely it is that librarians are to be introverted, but you would have to have a pretty massive likelihood ratio to make it the case that Steve is more likely to be a librarian than a salesperson. I like taking this case and then moving from this case to thinking about a medical example with our learners. For example, think about evaluating Mr. Jones, a 62-year-old man with a history of past MI, hypertension, GERD, active smoking, presents with progressive fatigue and an acute onset of dyspnea. He reports a non-productive cough, no fevers, difficulty breathing while lying flat, but no paroxysmal nocturnal dyspnea. His exam is notable for bilateral crackles and elevated JVP, but no lower extremity edema. How likely is it this patient has heart failure as the primary cause of their symptoms? The same approach can be taken, using the problem representation to frame the case and think about evaluation of a patient with an acute onset of dyspnea. You can find epidemiologic data pretty quickly, either based on your own literature searching, your own experience as you move forward in training, and to find things like, for example, about 35% of adults with acute dyspnea in the emergency department in North America have acute heart failure. You can look for data, again, either based on explicit literature searching or your own experience as clinicians move forward about the diagnostic weight associated with those pieces of information. And walk through the process of updating that pretest probability for the patient's history. In this case, the patient's history of MI and orthopnea are very predictive. And then physical, realizing that an elevated JVP in particular provides strong evidence. Now, as we move forward through our careers, we're going to encapsulate more and more of this together. An experienced clinician might evaluate this patient and immediately start encapsulating as this is a patient with venous congestion, for instance. But especially early on, as our trainees are weighing with the value of individual pieces of evidence, helping them to differentiate the pieces of evidence that have only modest impact on probability from those with a very high impact can be very helpful in improving accuracy. So the approach that I suggest to our learners is to take 5 steps in generating diagnostic probability, utilizing the problem representation, define a reference class, use an organized approach to identify the 2 or 3 most likely diagnoses, and then take the outside view. Rather than asking the question, how much does this sound like that diagnosis? Think about what is the base rate, what is the frequency of each of those diseases in your context. Then take the inside view, which is taking the case specifics, the history of the MI, the orthopnea, the elevated JVP, and update probability based on those highly predictive features. And of course, you're always going to know more about the patient than those specific features illustrate. And there should always be a final intuitive adjustment to that probability estimate. But that should occur after we've already walked through the process of taking the outside and then the inside view. I think we're about at time, and so I'm going to draw to a close here. Diagnostic reasoning, as I've mentioned, is dependent on a knowledge base gained through experience with feedback and enhanced by reflection. And I think that each of these can be enhanced and supported by the use of probabilistic reasoning. If you scan the QR code there, a number of the tools and resources I've mentioned, along with a list of suggestions for incorporating probability into your teaching, are included there. I've also listed citations that are referred to in the talk. I would love questions, comments, suggestions, ideas, either now or please feel free to contact me anytime.
Excellent. Thank you so much, Nate, for that talk on probabilistic reasoning and how it can be used to enhance teaching. That was so interesting, and I saw some really good comments in the chat as well. So we had a few questions come in, and so I'll share those with you. And again, if anyone else has a question that you would like to ask, please feel free to put that in the Q&A box or the webinar chat. We'll get to as many of those as we can. We had one question, does probabilistic reasoning necessitate teaching epidemiology and emphasizing that during med school? Oh, you're muted.
Thank you. Thanks for that question. Actually, this is one of the things I really enjoy about teaching probabilistic reasoning is that I think that so often, and maybe I'm reflecting my own experience, but going through medical school, we tend to think about epidemiology as the sort of boring, obligatory introductory section to reading about any given disease. And I think that using probabilistic language helps to highlight how extremely useful and important epidemiology is in our diagnostic reasoning. So yes, I absolutely think that using probabilistic reasoning requires discussion of epidemiology, and I think that's one of the strengths.
Excellent. Thank you. You spoke about ways to help learners practice uncertainty by using probabilistic reasoning. So, when you are working with learners, how do you evaluate and reward a learner's comfort level with uncertainty when most clinical reasoning practice prioritizes speed and accuracy?
Yeah, excellent question. As with so many tools, this needs to be used in the right time and context. Not every patient you see in a busy emergency room or clinic or ward is going to afford the time to have this sort of discussion. My opinion is that, similar to deliberate reflection, I think this is helpful for learning about simple cases, particularly with more junior learners, and enhancing the discussion around more complex cases for more advanced learners. I think that in aggregate, you can use tools like the Breyer score. And again, I'm happy to share more details with anyone who's interested in learning more about how to use and implement this to reward accurate appraisals of uncertainty. But I think even in individual instances, by focusing on probability and the justification for that, I think that we can really reward engagement with uncertainty. Too often, I think that in our clinical training environments, there is an implicit idea that uncertainty is a sign of weakness or incompetence, rather than the idea that sometimes saying that something is only 50% likely and we are not sure if it is the case and we need more information is exactly the correct response to a situation.
Excellent. There's a question about the reflection, the deliberate reflection. How do you think about that in terms of metacognition when you're asking a learner or a more expert practitioner to use deliberate reflection?
Yeah, that's a great question. So metacognition is essentially the idea of thinking about thinking, our own reflection on our cognitive processes as we are evaluating a patient case. And there have been a number of approaches studied for teaching metacognitive strategies to trainees. I think deliberate reflection is a specific example and a particularly effective example of that in many ways. What's been seen in a lot of the other literature on teaching metacognitive strategies is that teaching metacognition tends to improve calibration, which is to say, I might walk in the door thinking the most likely diagnosis is acute coronary syndrome, and with the application of metacognitive strategy more intentionally, I might leave saying, yes, the most likely diagnosis is acute coronary syndrome, and I am very certain or somewhat certain, for instance. Metacognitive strategies seem to generally improve that calibration, but don't necessarily improve diagnostic accuracy. I think the questions in deliberate reflection have a better evidence base in terms of actually improving diagnostic accuracy when used for challenging cases, as well as enhancing learning.
Thank you. And then this will be the last question. And then I'll have a couple of things to share with the audience. So how do you incorporate discussions of can't miss diseases when you are especially working with beginners about probabilistic reasoning?
Yeah, that's an excellent question. I think that, and it is certainly the case that sometimes this approach can be more helpful when we are thinking about differentiating common and overlapping diseases in presentation. For instance, does this patient with dyspnea have a heart failure exacerbation or a COPD exacerbation? I think that the same line of reasoning applies very well to rarer, more critical can't miss diagnoses, but we need to be careful in how we talk about it. And I would go back to the slide that I showed on diagnostic thresholds for testing and treatment, which is that even when we're talking about the extremes of probability, similar principles apply. For instance, I spend a lot of my time practicing in pediatrics, and we think a lot about the possibility of bacterial meningitis in febrile infants. That is not common, less than 0.5% in most cases. But it's a less than 0.5% that we're not generally willing to tolerate. And so we look for markers that will move that needle of probability either low enough that we don't need to, for instance, perform a lumbar puncture and administer empiric antibiotics, or high enough that we say doing this sort of evaluation and treatment is justified. So I think that the same language applies, but I think that we need to be maybe be careful to frame it for our learners when we're talking about cases that are living more in the extremes of probability. I hope that addresses your question.
Excellent. Thank you so much. And for anyone who put this question in the chat, we will be sharing the recording afterward. And so we'll also include a link to those resources that Dr. Stehouwer shared. So we'll be sure to include that in the follow-up email. And just a moment, I'm going to share with you another QR code. This webinar was brought to you by Lecturio, and we are happy to bring you these webinars free of charge, and we hope that they enhance your teaching and your practice. And if you're interested in learning more about Lecturio and our family of products, you can use the link that should appear in the chat, or you can scan the QR code on the screen, or you can just watch for that follow-up email, and we'll be sure and get that to you. So Lecturio has acquired NEJM Healer, and that is a clinical reasoning teaching platform. And so if you are interested in staying for a little while after the end of this webinar, my colleague, Dr. Stefanowski, will be doing a demo of NEJM Healer. And I think if this is a topic, this webinar was a topic that interested you, you may be interested in seeing that demo of NEJM Healer. So if you're interested in that, please stick around. That will be in just a minute or two. Again, we'll share the recording in the follow-up email along with a survey that you will see. If you need a certificate of attendance for attending this webinar today, please answer that question in the follow-up survey, and it will generate the process for you to receive a certificate of attendance today. So that's how you receive a certificate of attendance. You watch for the follow-up email and you answer the question for a certificate in that survey. All right, if you are interested in more webinars like this one, we have on the calendar for Wednesday, November 12th, Anthony Miller will be speaking about the future of PA education. We'll be talking about AI and other factors in the future of PA education, and be on the lookout for other webinars being scheduled soon. All right, and this is our contact information. If you need to speak to us about anything, we would love to hear from you. That's learning-science@lecturio.com, and I will receive that. And so I would love to hear from you. So if you're interested in sticking around for the demo of NEJM Healer, I want to thank one more time Dr. Stehouwer for that very informative talk. That was excellent. And I think it leads us nicely into a demo of Healer, the Healer product. And I'm going to hand it over to my colleague, Dr. Goran Stefanowski, who will be doing that demo for us today.
Hello, everyone, and thank you, Dr. Keith. And thank you, Dr. Stehouwer, for that wonderful talk. And what I really love about this is I can do the demo for Healer or Lecturio, but I also always learn something new just by being at these webinars and attending. So in the next, I would say 10 to 15 minutes, I will try to walk you through Healer. So some of you might already use Healer, some of you might have used it in the past, but just in case you're not familiar with this platform, we'll take a little bit of your time to to walk you through the platform. In case you don't have the time or the capacity to stay, thank you so much for being here, for attending this talk today during the day. For those of you interested to know more about this, feel free to contact us. So you could contact any of us directly, or you could send us an email to the email that was previously shared with you, which is learning science with a dash at lecturio.com. And some of us can do more personalized demo and show you this platform a little bit better, and give you more attention with it. Okay, let me just open the platform. So if you have seen it before, you know what to expect. If not, the Healer platform looks very modern. It's a very, very modern platform. So this is sort of the dashboard of it. This is the internal Lecturio one that I use, but you will look at this from a different perspective, and you can look at this from a learner application or an educator application. This is what the educator is really looking at. So the platform has clinical reasoning science embedded within it. And it is one of the most comprehensive clinical reasoning teaching apps that exist out there at the moment. There's various things we're going to do together today. First, we're going to look at the resources just to kind of let you know what the platform is based on. And then I'm going to kind of walk you through a case without diving too deep into the case, because they typically tend to take more time. So you have resources for educators and also for learners and educators together. Let's just take the one for educators for now, because I want to let you know what the platform is really based on. So the original article that discussed clinical reasoning back in 2006 from Dr. Judith L. Bowen about the educational strategies to promote clinical diagnostic reasoning is the basis for the creation of this platform. This was since reviewed by people together with Judith L. Bowen that updated and upgraded this original paper, and then they decided to create a full platform around it. And especially in time of digitalization, this is very, very important. These are things you already heard about during the talk today. You already discussed. So the key elements of the clinical diagnostic reasoning process are embedded within that platform, and this is what we're really trying to achieve by using it. But the most important part that I want to show you, because this is something we will see once we go through the case, is really this defining and discriminating features of a set of diagnostic hypotheses. And ironically enough, we're going to look at arthritis today as well. That's the case that I chose for you. But this is about creating the illness scripts and being able to discriminate when we have certain symptoms, which of these symptoms is pointing us toward which diagnosis, and which of these symptoms make it less likely for a diagnosis to happen. So when you have students, especially when you have more novice learners, this usually tends to take more time, and it means that you can also see how in depth these students are going, and how much attention are they paying to all the symptoms and to all the findings within a case. I've personally used the platform both as a learner for clinical reasoning, but also as an educator. So I will kind of embed that within the talk as well. So there's many cases, and those cases can really be seen through the chief concern here. And as an educator, you're also able to see which of these cases or what's the diagnosis in these cases. This is us seeing the platform through the learner's window, so through the learner's perspective. So in here, you have all of these chief complaints here, and you could use different filters so that you can kind of pick which one of these cases you want your students to do. You're also able to assign these cases so the students can take these before the clinical rotation, or you could do them together in a problem learning setup. So what I've chosen today is George Harvey. So a person whose chief concern or chief complaint is arthralgia. So what we're going to do is we're going to start over this case, and I will quickly guide you through it. This is what the platform is really looks like, and I want you to be able to really just see it. I'm just going to move this there. So you could start the case with guidance or without guidance. What's really important here to note is that the guidance guides you through the platform itself. So if you start a case with guidance, you're not going to be guided through the medical aspects or the clinical reasoning aspects of the case, but rather just the platform. And without guidance, if you're already not new to this platform and you know it very well. So here you get all these tips on what you need to do. But this is what that case really starts as. So You do have the general context of the patient, where the patient is from, because that can be important, and everything else. And if anything is out of the ordinary, would be written in red with a small exclamation mark in front of it. So now, when you're going through this case, especially again if it's with students that are just about starting clinical reasoning, it is very important what they're going to use and click through as findings, right? So, for example, patient's age. The setting can also be very important. Patient's gender and sex recorded at birth. What is out of the ordinary? Are we expecting a fever, temperature, or not? So anything written here that might be important to the case goes in findings. Then in the end, when you get an overall grade of your performance, how in depth have you gone also does help with the percentage of you know, how careful you were with what you chose or not will be seen, and we'll see that a little bit later. So in here, we do have the questions already preloaded. So this is perfect for novice learners, but if it's for someone for later, they would just kind of click through. So the patient has wrist pain, and then all of these other questions show up. So for example, both of his wrists hurt, he's had it for years, he feels it all the time, never had this pain before, so this is kind of new. You ask them to rank it, right? So all of these findings will really help us with creating a diagnostic, so differential diagnostics, but also create the illness scripts that were already discussed in the webinar earlier. So in here, the student or yourselves need to write down information. So we have, for example, a 59-year-old male, and then you can add to this problem presentation throughout as you go and all the findings that you have. Adding differential diagnosis is required from the beginning. You can add as many, as little, or as few, or as many diagnoses as you want. Last time I did this with students, it was a larger group, so we did it together. So in the beginning, they had 15 diagnoses. And then as we really went through, these diagnoses tend to be reduced because they would say, well, remove that because we now know it's not this or it's not that. So in this case, because he has, you know, pain in his joints, basically, did it just say, no, it says wrists. So in his wrists, we can add any diagnosis that one. Rheumatoid arthritis could be one. Let me just see. There it is. Then it could be viral arthritis, for example. And we could add pseudo-gout maybe, because gout would be somewhere else, right? So we have at least three, and at least three is what you really want in the beginning, at least. Then we're moving on to the medical and social history. So you can see what the patient has here. And this is pretty comprehensive because sometimes patients also tend to have something that's not necessarily part of the chief complaint and of the diagnosis that we're looking at here. Has the patient had COVID or not? Usually it's never if the cases were created prior to COVID. What medicines are they on? Are they taking them as prescribed? Any allergies? These are things that your learners would, or your trainees would ask their patients regardless of where they are, right? So you have the family history here, and you also have social history. So is he exercising? What is his exposure history? Has he traveled? Is he drinking alcohol? Where does he, you know, live? His nutrition. So you have all of these aspects that might help form a diagnosis by the end. Now, in the review of systems, you're basically just asking him additional questions. So what typically students like to do is they like to click through everything just in case they miss something. So the more advanced your learners are, you really want to pay attention to specific systems here, and you don't want them to be to click through everything all the time, because if you're simulating this to look realistic, you won't have realistically 50 minutes to discuss with patients. You can always go through general, you know, it asks about appetite, has he been feeling tired or fatigued? And what's really important here is that whenever you have something positive, an array of questions tends to show up so that you do a follow-up of these questions. And this is great for students to also see what kind of questions typically are being asked regarding a certain symptom or a sign that the patients share with you. So this would be like, when did this fatigue or feeling of tiredness started? Hasn't been consistent. When does he feel tired throughout the day? Hasn't been getting worse or not? So you're just clicking through everything you deem important at this point in time. So because this is pain that he has on his wrists, we really don't have to go through respiratory cardiovascular perhaps at this point in time, but we could technically go to musculoskeletal, right? So this joint pain is already here, so this is already clicked through from before, but now we're asking about swelling, and he does have it for a few months. Hands and wrists get swollen. It does come and go, right? So you really do dive deeper into everything that this patient tends to have. We see there's joint stiffness. I think one of the most difficult aspects with students here is to also let them know that sometimes having a negative, right? So for example, any issues with joint mobility, and to know that this can be an important finding indeed, because in certain diseases, if you do have issues with joint mobility, that does tend to change your differential diagnosis and how that goes, right? So we go through the end, everything else seems to be fine, and you could have to add something else to your problem presentation, but for the sake of time, we're not going to do that. Again, if you want to be able to try this yourselves and to have someone from our team walk you through, we will be able to take a more comprehensive demo where all of this will be done. Now, the important part in each of these steps is to re-rank your differentials as needed. So let's say viral, because from things we found, is less likely, we could move this lower and have pseudo-gout as the second. And in the end, this ranking that you've done is important in how you're being evaluated here. Now then we move from triage to history to physical exam. The physical exam kind of follows a similar pattern with a history. So in here we could do the general exam and the appearance here, right? So you can say, oh, skin is normal appearing, no apparent distress, no normal body odor. Like, so you could go through everything again, but for us, upper extremities seem to be more important at the moment. So we see there is erythema around wrist and BIP joints. There's swelling, there's proximal interphalangeal joint swelling, no distal interphalangeal joint swelling. So all of these little details, the more experienced you are, mean more in creating or getting to the final diagnosis. You could do palpation, so we see that edema, which, the swelling, it's bilateral and the pulse is present. Right? So there's no tenderness, and you can just kind of choose everything to be part of these findings. And obviously you can check, let's see the lower extremities, right? Just because if this is gout, they might actually have something. But when you see that everything here is normal and normal on palpation, you will can say, okay, so everything is fine and we can continue forward. Obviously here, everything we found, like that swelling, PIP joints and everything else, can be and should be added in the problem presentation so that your students can have it in the end. So let's continue in the next step. So in the next step, we're going through the diagnostics. Now, the issue here is that these diagnostics are preloaded, right? But if you're doing this in person, before clicking this, you might ask what it is the students that want to do. So from labs, you have chemistry. You will see that everything seen here appears to be normal. The liver function tests are normal. The complete blood count, the CDC, is there. We've done immuno, so antibodies for rheumatoid factor are positive. Anti-citrulline protein antibodies are positive. In inflammatory, we have the sedimentation rate and the C-reactive protein being both positive or elevated. The enzyme-linked immunosorbent assay, Borrelia burgdorferi, was IgM is negative, so that was also ordered. So this is good to see if your learners would do this or not. And if you have imaging that you have ordered, it will be here. So there's joint space narrowing, bone erosion, and soft tissue swelling, particularly and see all of these details help you with the final findings. Now, when this is all done, what you want to do is re-rank these. Let's rank viral arthritis just because as a second one. The confidence level here is very important. So for your learners, you need to know, like, I know what the diagnosis is. I think so. I'm unaware. I have no idea. And then the mentally demanding of this encounter is also important to note. So let's say this was a 5, sometime in the middle, and then you submit. However, this is not where the story ends. So you do have the efficiency and thoroughness. I feel like you want your efficiency to be higher the more experienced learners you have. Your thoroughness needs to be larger when the students are just about starting. So here we have three top diseases that our experts have actually done. So they didn't do viral arthritis, they did do OA. So we have missed that. And when we're building an illness script, this is going to come up again. But here you can see from the data acquisition, what was it that we got right and what was it that we very much missed, right? So, for example, the absence of chest pain is something that is important. The chills and rigors, the fever, the night sweats, the weight change, even though these are negative, they're important with the data acquisition part of efficiency and thoroughness. Now, once this is done, what we really need to do, and this is where things get really, really interesting, and this is where you get deeper into clinical reasoning, is you have to take each of these symptoms that we found and each of these findings and say, so by having a joint pain location in bilateral wrist, the chances are that all three, for example, are true. Or the joint pain occurrence in years makes it more, possible to have pseudogout and RA, for example. So your learners have to do these for all of this. If you don't like to do it, you can also click through. I'm not really thinking about this. I'm just kind of clicking through, but you have to go through all of these findings, right? So this being positive, like RA is more important, right? So the X-ray is also giving us something, but you definitely need to do all of these. And now the important part here is that you also have findings that make this disease or diseases less likely. So the no DIP swelling could be this, right? So these need to be kind of clicked through as well. I'm just clicking again because if I start thinking, it will take us a very long time. So once your illness script is built here, you see all of the findings that make something more or less likely, and this helps you create your final idea. So you have the top three diseases of the experts. Which one is the most likely? Let's go with rheumatoid arthritis, and let's say this is probable. Now, you could order additional diagnostics here. You could do patient counseling. You could do referrals, treatments. You can say, we're giving the patient non-steroidal anti-inflammatories, glucocorticoids, anything. The timings, are you doing discharge follow-up? If you're admitting this patient, let's say we're going to admit the patient. Oops, that's caps lock. And you need to indicate your degree of concern, which is also important in the final handling of this case. Now, after that's done, you submit this case for review. And at this moment in time, what you need to do is check your own patient history and triage with what the experts said and kind of cross-compare it. And you see at every part, after the history, after the physical exam, there's more information being added because, as I said, you need to build your patient script. And then you can self-assess and say how similar these were. For us, I wasn't really typing, so these are not similar if we're being honest. And then you continue to the management plan that you also can check. Now, what we're really in the process of doing is adding AI to this so that AI can give you feedback. So this is not just going to be self-assessed, but AI can kind of tell you how close this is, how similar it is. And keep in mind, we are reasoning this aspect as well. So we're not expecting this to be fully the same, right? We're kind of expecting for this to be somewhat similar or to have the key points and the keywords that are needed here. You can kind of see what the expert has written. And this is a really good practice for patients to actually do this in the clinics as well. And again, I was just clicking and typing, so this is not similar at all. Then you finalize the self-assessment basically, and you can have audio feedback if needed. So in the summary, the efficiency and thoroughness is something we already saw. We did have the revised lead diagnosis to be correct, but the lead diagnosis throughout the case was not right. There's concordance with what the experts have done, and then you can really see resources through all of this to know either learn more about something related to the disease, or you could go through the resources with the explainer to see how this grading happened. You see the diagnostic accuracy here, so you can see at which point what was needed and what needed to be written. So see the experts, apart from these diagnoses, wrote carpal tunnel and psoriatic arthritis, Lyme disease, which is why we tested for this, gonococcal infection and everything else. You do have the data acquisition in greater detail here, so you can read what the references are and why this is important. The illness script concordance, so I was just clicking through, as I said, so you can see that ours is somewhat different. I did get a few right just by clicking on them randomly, so that's good, but not good enough, right? Problem representation as well, you can kind of read it here and see what the expert has done, and in the end, you have the management plan written and typed out by our experts. So you have the key there, and you can kind of see what is the percentage of similarity and the concordance. Now, you can print this report so that you can use it for later, but you have over 132 cases like this, and more cases are coming. So this is NEJM Healer in a nutshell. This was the sort of fastest I could have done to present this to you, but feel free to reach out and to ask us more questions, because we would love to be able to showcase this to all of you. And thank you for sticking with us till the end of the webinar today. Dr. Keith, handing the baton back to you.
Excellent. Thank you so much, Dr. Stefnowski. We appreciate that. I always love seeing that demo of Healer. It's such a great product, and especially today, seeing how that problem representation can evolve. I think that was a great callback to the material in the talk today by Dr. Stehouwer. So thank you again, Dr. Stehouwer, for that talk. That was excellent. And for those of you who stuck around, thank you. We hope to see you at our next webinar. Enjoy your day.